would like to thank Alexion Pharmaceuticals, argenx, Horizon Therapeutics, Janssen Pharmaceuticals, Regeneron, and UCB for their generous support of this symposium. It's now my pleasure to welcome and introduce our first presenter, Dr. Constantine Farmakidis. Dr. Farmakidis is an associate professor of neurology at the University of Kansas Medical Center. His focus is on neuromuscular medicine. Within the University of Kansas Health System, Dr. Farmakidis sees patients with a broad spectrum of neuromuscular diseases and has a special interest in myasthenia gravis and neuromuscular junction disorders. He participates in multi-center clinical trials in MG and investigator-initiated studies of this disease. He is also active in the Myasthenia Gravis Association in Kansas City, giving talks, participating in patient support group meetings, and serving on the organization's medical advisory committee since 2017. Dr. Farmakidis obtained his medical degree and neurology residency training at the University of Rochester School of Medicine and subsequently completed a fellowship in clinical neurophysiology and EMG at Columbia University. He holds board certifications in neurology, neuromuscular medicine, and electrodiagnostic medicine. He's also a member of the Alpha Omega Alpha and Gold Foundation Medical Honor Societies. Thank you for being here with us today, Dr. Farmakidis, and I will now turn the time over to you.
Marissa, thank you so much. Can everybody can hear me okay? Great. So yep. Let me go ahead and share my presentation here. So good afternoon, everybody. It's really a pleasure to be able to join for this MDA Engage Symposium. And thank you for organizing. It's really great to be here with everybody. So the purpose of today's talk is to talk a little bit about how the treatment landscape of myasthenia gravis is changing, why it is changing, and what are some of the implications in terms of treatment decisions and management for patients that are being treated for myasthenia. So first of all, some disclosures. As Marissa mentioned, I am involved in multi-center, clinical trials for myasthenia gravis investigational agents. None of these, they're not approved, they're not mentioned here, and I'm also involved in some consulting as well. So 2017. So why is 2017 an important date when thinking about the treatment landscape of myasthenia gravis? Well, 2017 is the year that there was the first new myasthenia gravis FDA-approved drug since 1955. So 60 years or so, a little bit more than that. And then that was the first one. In 2020, there was a second. This was a first-in-class. So completely, it was a first-in-class, medication, and it was approved for myasthenia, a terminal complement inhibitor. Then in 2020, there was another first-in-class medication. So all of a sudden, there's two after 60 years plus. And then in 2022, there was another one, Ravulizumab. So, it's basically a time of change and a time of a lot of developments from a pharmaceutical standpoint and also from a clinical standpoint, for patients that are being treated with myasthenia. So why are all these, what has ushered this time of change? Basically, a couple of things have come together. There's been, myasthenia has always been one of the best studied and one of the best understood autoimmune conditions. And at the same time, there's been advances in drug engineering and recombinant DNA technology that have made rational drug design. So the idea where, you can develop a drug based on a rational target that is a specific target in the mechanism and pathophysiology of a disease. So there's tools that make that much more realistic. Also, there's been a lot of sort of institutional learning, a lot of infrastructure that's been developed around the world that has made it possible and sort of a lot of expertise in running these multi-center clinical trials where you have to recruit patients that have not a very, very common condition, and then coordinate these sort of massively complex undertakings. And there's been a lot of experience, a lot of infrastructure, whether it is digital infrastructure, whether it is, expertise for data monitors, for site monitors, for central labs. And yeah, and that's made it that it's become, there's more knowledge as to how to run these essentially global clinical trials. And then also, the pharmaceutical market rewards innovation. And I think that's provided an incentive to undertake, these really large drug development projects. Just to kind of illustrate how the change has come with all these drug developments and the change in the amount of clinical research that's being done in myasthenia, I'm just going to share this graphic, this figure from a recently published review. It basically shows, you'll see on the bottom of your screen, 1940s, you'll see a timeline, 50s, 60s, 70s. And then there's the empty dots and the filled out dots or circles. And these are clinical trials as they happen in time. And then the filled out circles are clinical trials that had positive results. So between 1940 and 2000, there's a handful, 2, 4, 6, 8 clinical trials. A couple of them were positive, great. And then let's look to see what happens in the next 10 years. So in the next 10 years, there's close to 17 trials. So in 10 years, you have 17. And then between 2010 and 2020, there's again another doubling between what was done the previous 10 years. So all of these factors, coming together, better understanding of myasthenia, better drug technology and techniques and technologies for rational drug design, and then institutional knowledge and infrastructure around the world, and the studies are increasing, and that is what led to approvals, new drug approvals. So this is sort of a historical big picture of to set the stage for our discussion. So as you all know, the drugs related to pyridostigmine were the ones that were sort of discovered first. Mary Walker in the 1920s had this insight that physostigmine could have a role in the management of myasthenia, and it did. And then there was thymectomy, and then of course corticosteroids in the 1950s. And then between the 70s and 80s and 90s, there's been sort of an array of broad spectrum immunosuppressive therapies, the so-called sort of traditional agents. And then following this, dramatic increase in clinical trials and clinical research, there's been sort of, a new sort of era with biological agents that often borrow the molecular structure of antibodies. And one of the advantages of antibodies is that they can be very, very specific in terms of their binding affinities. So once you can have a very specific molecule, you can really target a very, very specific compound in the human body. So basically a harnessing of human antibodies and their ability to be very specific in order to intervene in drug disease physiology. So Rituximab here, that's not an FDA-approved medication for myasthenia, but it does have a very important role in the management of MuSK-MG. So that sort of started to come into practice around 2010. And then, as I mentioned, Eculizumab, FDA-approved in 2017, FcRn in 2021, and then Ravulizumab in 2022. So that's the big picture. What I'm showing here is an algorithm for the management of generalized myasthenia gravis. And this is not a patient, in crisis, and different places might do things a little bit different, but the big picture I think is captured here. And I'm showing this to illustrate, where some of these novel agents sit in the way that, we practice, I think, here at KU and probably at other places as well. Of course, you start with pyridostigmine, and again, all the patients are a little bit different with myasthenia, no question about it. But in general, pyridostigmine, thymectomy has a a very important role, whether you have a thymoma or whether you don't have a thymoma, but you're acetylcholine receptor antibody positive, prednisone, traditional agents. And then over here, if you can see the pointer, that's where, the novel agents come into play in the way that, we manage myasthenia. So let's see here. Okay. So unmet needs in myasthenia gravis. So despite this, the progress, the incredible progress that has been made in the management of myasthenia, this was a disease that was called gravis for a reason. It used to be severe, really severe, and have a high mortality. That's no longer the case. There's morbidity, there's patients with symptoms and unmet needs, but patients having very, very poor outcomes is actually now very, very uncommon. But there's still unmet needs. So let's review them a little bit as a bit of a prism for looking at these novel agents that were more recently introduced. So, first of all, a cure would be great. Could there be a way to make the myasthenia symptoms go away, and even the need for some of these not always easy medications to take go away? So it turns out that, a complete remission, no symptoms, no meds, is quite rare in myasthenia. It's about only 20% in most myasthenic patients, so antibody positive, seronegative, and as low as 4% for patients with MuSK. So that's an unmet need there. Prednisone, of course, a very powerful medication, a game-changing medication when it came out, but still, medium to long-term, problematic. It can be associated with very, very serious side effects, life-changing side effects. And then, the traditional agents like azathioprine and mycophenolate or tacrolimus, cyclosporin, medications like that, the sort of broad spectrum immunosuppressant medications, the time of onset is delayed. And yeah, I see the slide is blank. That's right. I just want to be able to, I have a couple more things, but I wanted to go ahead and just talk about them and try to describe them, before just putting up information. So thank you for the message, but I was hoping to keep a clean slide as much as possible, and I talk to the audience. So so basically, yeah. So unmet needs. The broad spectrum immunosuppressive agents, they are they can take a long time to start working, and there are significant side effects and organ toxicity, and they require close monitoring. And toxicity is not uncommon, so that's a concern there. And here, this is the full slide that Mr. Sokol, you're gonna have access to. This is, but the molecularly targeted, these biologic therapies, they're very costly, and also a potential downside is that once you start taking an infusion that is every 2 weeks, or where you get a cycle of 4 weekly infusions, you have to go to the infusion center, or have these infusions done. So you kind of medicalize your life rather than sort of have lower impact treatments that you can sort of handle on your own time or with less of a time commitment. And of course, even with all these treatments, patients, come into clinic and they describe incomplete treatment effect. And, there was a paper that captured the patient perspective in myasthenia gravis, a paper that was published by Nancy Law, who was the former president, but previous president, of the Myasthenia Gravis Foundation of America, on the patient perspective. And, that's a quote: fluctuating and unpredictable symptoms, treatment inertia. So still lots of work to do. Okay, so the next slide here is sort of like a wonderful illustration by Dr. Howard's paper in 2017 that starts to talk about the pathophysiology, so the mechanism of myasthenia gravis. I'm just checking the time here. So the mechanism of myasthenia gravis. So basically, it's a T-cell mediated disease. You'll see that here on the upper left-hand corner. So it's the T cells that become, reactive to self, and they become reactive to, most commonly the acetylcholine receptor antibody. And then they prime B cells. Once they become autoreactive by mistake, by error, they prime the B cells, and the B cells mediate the disease by producing the antibodies. So T cell driven, B cell mediated. And then once you have the antibodies that are released here, you see them, they're released in the B cell, they can do a couple things to mediate the injury at that nerve to muscle sort of electrical chemical connection. So you can have blocking. The antibody here, it blocks the receptor, and you can't get the neurotransmitter to bind to the receptor and activate the muscle. Another, actually, probably even more important mechanism is the cross-linking. So the antibody, the acetylcholine receptor antibody here that's released by the B cell will bind and cross-link the receptors, the acetylcholine receptors, and in this way accelerate or shorten the lifespan of each of the receptor on the muscle membrane so that there's quicker internalization. So you have fewer receptors, you basically take them out of the circulation, you knock them out sooner. And also another very important mechanism, and mechanism that is directly acted upon by these terminal complement inhibitors, is basically complement activation. So you see here complement activation. So the IgG antibodies can activate the part of the innate immune response that's sort of complementary to antibody activation. And the end result is that there can be sort of a pretty aggressive, activation and damage to the membrane of the target cell, particularly with a complement system. Once the components of the complement, the terminal complement, come together, they create kind of like a hole punch device that punches a hole through the cell membrane here, the muscle membrane, and then lyses it, so sort of destroys it, and it looks like this. So hole punch onto the cell membrane or the muscle membrane, and then you sort of destroy these intricately organized parts of the muscles of the muscle membrane, and then you can interfere with the transmission, the neuromuscular transmission in myasthenia gravis. Okay, so these are the treatment options for maintenance. This is one way of looking at first line, second line, third line. This slide is up here to basically show that some of the medications that I'll be talking about next, these novel agents, these new drugs, recently approved drugs, are currently our third line for a couple of reasons, they're right there. Okay, so let's start with Eculizumab. So Eculizumab is a monoclonal antibody, and it has, like antibodies, it was designed to have very, very specific, antigen specificity, and it basically binds to a key common component of the complement system that I spoke about earlier, and blocks the formation of that hole punching mechanism that I showed in the previous slide. So it's basically a terminal complement inhibitor. This is the complement system right here. Don't worry about it. C5 is right here, which is sort of the final common point of activation, which allows C6, C7, C8, and C9 to come together and make the the hole puncher, the MEC, the membrane-tau complex. So the idea with these drugs is that if you bind the C5 right here, then you don't get that hole puncher, and you're not able to damage that complement-mediated damage at the nerve muscle, at the neuromuscular junction. So this is what it looks like right here. So you have this lock-in key, and basically you just lock up the C5, and then you block the formation of that hole puncher. So let's look at the the studies that the new data that eventually led to the approval of Eculizumab. So the phase 3 studies are the studies that are designed to demonstrate that a drug works, and also to monitor, and also to assess whether there's an acceptable safety profile. So this is the phase 3 study for Eculizumab. was performed, 2016, 2015, with some of the most affected treatment-resistant patients with myasthenia gravis at the time. It should be noted, although you'll see why this is no longer important. The primary outcome, the thing that you look at to say, okay, the drug works or the drug doesn't work, let's keep it cut and dry. This is the primary outcome. It was actually negative. Let's see, why are many treatments? Okay, so we'll get to that. We'll get to that later. But thank you for your question. The primary outcome was negative. However, what happened was that there was a whole series of secondary outcomes that were looked at that were positive. They were consistently positive, one after another, and that led to the approval of the drug. An example of that is the minimum amount of improvement in the MG-ADL score. The MG-ADL score is a patient-reported score for activity of myasthenia gravis. And basically, blue is the Eculizumab, red is placebo. So basically, these are the patients that were not getting the drug in red. And then the minimum 3 points. So improvement is good here. The more improvement you have, the better it is. And you can see that consistently, the MG-ADL improvement was more in the blue squares. So for example, 60% had at least 3 on the drug and 40% on placebo. And then you go further up and you'll see for a 6-point improvement, at least 6 points, it was 39% for Eculizumab and 18% for placebo. So this was, evidence that maybe this drug does work. The QMG, that's a quantitative myasthenia gravis score, but it's a quantitative neurologic examination, so less room for, interpretation there from the patients. And you can see the size of the placebo effect is not as prominent. 60% had at least 3% on Eculizumab and 40% on the placebo, whereas 45 and 19. So the QMG score again showed an advantage for Eculizumab, and then there was the extension study. So the extension study, what they did there, what was done there, was that patients that were on Eculizumab in the blinded study, the patients, the first part of the study was blinded. So some people got placebo, some people got the drug. But in the second phase, in the treatment extension, the people that were on the drug, Eculizumab, they stayed on the drug. The people that were on placebo, they were transitioned to the drug, Eculizumab. And that was done for 4 years. So, and look at this. These are some of the sickest at the time patients, the most treatment-resistant patients. And what you'll see here, up until this dotted line, this was where you had 2 groups, where red was the patients on placebo. So they had, this is their change in the MG-ADL score. So the red, the patients on placebo, they didn't have that much of a change. The ones that were treated on Eculizumab had more of a change. And then very, very notably, look at this. The day that you start giving to patients on placebo, you give them Eculizumab, within a matter of 2-3 weeks, their MG-ADL goes down and reaches the level of the treated patients. So very, very strong evidence of efficacy there. You block the complement system in these acetylcholine receptor antibody patients, and patients do better. Same thing with the QMG score. You'll see in the blinded portion of the study, there's a clear difference between placebo and treated patients. And then once you cross that dotted line, and the patients that weren't getting drug, here on the red plot, start to get drug, and boom, there's the QMG score comes down and becomes very similar or equivalent here to the patients that are getting the drug. So again, very strong evidence that this is an active medication that has an impact or that has an effect on disease activity. The safety outcomes. So for Eculizumab and these terminal complement inhibitors, the first thing to mention, and just kind of, you can take your eyes off the slide. This is sort of a different comment. So what I want to say is that the complement system has an important role in fighting off certain bacteria, and particularly encapsulated bacteria, and in particular meningococcus, which can cause a very serious meningitis, so brain and sort of brain lining inflammation. So all the patients in these studies were vaccinated for meningococcus. You need to get 2 different vaccines to cover, a broad, the broadest number of serotypes, of sort of bacteria types. And this was done in the clinical trials, and it's also virtual. It's basically mandatory, if you're going to be on the medication. But putting meningococcus aside, and I'll talk about it in a second, the safety outcomes between eculizumab and placebo are very, very similar. You look at the most common adverse events, and it's headache, and it's 16% in eculizumab, 19% in placebo. You look at upper respiratory tract infection, the second most common. So URIs, eculizumab 16% and placebo 19%. So, an upper respiratory infection or nasopharyngitis, sore throat, runny nose, 15% for eculizumab of the patient, 16% for placebo. And then myasthenia gravis, well, it's more common in the, there's more disease activity in the placebo treated group, which makes sense. So, the safety outcome was good. And then, serious adverse events. So these are the safety outcomes, and these are patients with more serious adverse events. And they're, again, comparable between eculizumab and placebo. And then there's the open label extension. This is the, that second study that I showed. And you can look at the most common adverse events. And again, it's, headache, sore throat, diarrhea, upper respiratory tract infection, joint pains, but no signal of something highly dangerous. And then these are the most common MG, myasthenia gravis, and infection-related serious adverse events on the right side of the screen. And there were 3 deaths, but those were felt to not be related to myasthenia gravis. And then there were some other infections as well, which underline that yes, there is still some immunosuppressive effect there. And that's the overall safety profile. Okay, so I mentioned that let's make it important to make this point. The terminal complement inhibitors, these medications like eculizumab, they interfere with the immune system's ability to fight off meningococcus. So there's an increased risk of meningococcal meningitis. It's been estimated to be around 1,000 to 2,000-fold higher. You need to get a vaccine, serogroup B, and then the ACYW serogroups. And there's you need to get vaccines initially. There's boosters, and then you need to restart the cycle every couple of years. So that's very important to monitor your vaccination status and remain up to date. Okay. Let's see. Okay, so moving on to Ravulizumab. So Ravulizumab is the drug that was approved in the spring of 2020. The reason I mention it a little bit out of order here, because there's efgartigimod that was in between, is because Ravulizumab is also a terminal complement inhibitor. So just like eculizumab, it has the same mechanism of action. It's designed, you use the power of antibodies to be very, very specific in their targets, to just go after, out of all the molecules in the human body, to just identify C5 and then block C5 from being cleaved into C5a and C5b and activating the terminal complement complex and the membrane attack complex. So how's Ravulizumab different? Well, this is sort of another great example of rational drug design. Drug engineers, chemists, biologists, they said, well, what can we do to make this antibody more durable in the bloodstream so that it doesn't need to be administered every 2 weeks? What's the next generation compound that we can develop? So basically what was done was they changed some of the amino acids to make the drug more resistant to the natural degradation pathways in the human body for antibodies. And then also they said, well, how can we take advantage of this natural recycling program for antibodies in the human body, the IgG antibodies. How can we take advantage of these innate processes for recycling antibodies so that the drug can be recycled and sort of remain in circulation for a longer period of time? So Ravulizumab, just like Eculizumab, was tried in other diseases that are complement mediated. It was found to be effective there. And then you can also monitor complement activation in the human body through assays. And they said, well, we're achieving complete complement arrest, you're knocking it out for 8 weeks. So it looks like, yeah, this works for 8 weeks. Let's try it in myasthenia gravis. And this is what was done in this study. This is another, large international multi-center clinical trial in myasthenia gravis for Ravulizumab. This was recently published, so April of 2022. This is very recent information. And again, now we're looking something pretty similar. So this is the change, this is the primary outcome. So the change of the MG-ADL score over basically 6 months in placebo versus Ravulizumab. And this is weeks, sort of on the bottom axis here. And you can see that within, 2 to 4 weeks, and the MG-ADL score has declined here. And then after 26 weeks, so basically half a year, it's statistically significant. There's a statistically significant separation between placebo and Ravulizumab. Now, it's not a very large, difference. It's sort of, but there is a statistically significant difference. When looking at this, you can say, well, no, it's not a statistically significant difference, but recall that the patients for the REGAIN study, they were probably, at the time, they were probably more effective than the patients here. So this is a more sensitive study and maybe picked up a difference better. So this is the MG-ADL score. And then this is for the same study, another outcome. And this is the change from the baseline in the QMG total score. Again, this becomes, the Ravulizumab has a greater decline, so minus more points on the QMG score. So it shows clinical effect compared to placebo at half a year. So more evidence that it works. This is the sensitivity analysis showing, what proportion of patients had a at least 2-point decrease, at least 3-point. And you see that at every level, there's a greater proportion of patients that are treated on Ravulizumab that had a certain number of a decline in the MG-ADL score. So purple here is favored than the red lines. So for example, let's say greater than 4, what percentage of patients had a greater than 4% decline in the MG-ADL score? It's 42% in Ravulizumab and 24% in placebo. This is another sensitivity analysis. And again, Ravulizumab seems to, consistently do better than placebo. Again, strong evidence that it's working. These are, again, the adverse events. And if you look at the adverse events, Ravulizumab versus placebo, again, really, really very, let's look at headache, adverse event reported in greater than 10% of patients. So headache is 19% for Ravulizumab, 26%, so more common in placebo. Diarrhea is 15%. In Ravulizumab, 12% in the patients. Nausea is 10 and 10%, so the same. And then, any adverse event by severity, you can look at that. And overall, pretty comparable, so no signal for something, really problematic. Okay. So the next drug to talk about is FcRn. So FcRn is it's another one of these biologic agents. Again, it harnesses the ability of antibodies to very, very specifically, unbelievably specifically, target certain molecules in the immune system and in the human body. Basically, this antibody is modified to increase the affinity of the FcRn. Basically, it's a neonatal Fc receptor inhibitor. And basically what that does, I mean, I think the key thing to take away from this, how does efgartigimod work? Well, basically what it does is that it inhibits the human body's natural systems for maintaining IgG in the circulation. Because, you need IgG to protect you, at least in theory, you need IgG to protect you to have a strong immune system. And what the drug here does is it interferes with like the recycling of IgG, so it knocks down the levels of IgG in your blood. There are some similarities to plasma exchange, which, among other things, it also knocks down your antibodies across the board. So here you can knock down the IgG just by using efgartigimod and by blocking the recycling of IgG so that it doesn't so easily stay in circulation. This is sort of an example of what I talked earlier about how the scientific understanding, increased understanding of the immune system has provided the platform, the foundation for all these advances in treatment, which we're seeing the results of now. 20 years ago or so, but a while back ago, I should say, it was discovered that the neonatal Fc receptor in humans had a role in the maternal the transfer of maternal antibodies from the mom to the baby, so that's sort of where it was discovered. And then it was discovered that it wasn't just from that the neonatal Fc receptor had a role in maternal fetal circulation. It was also discovered that it had a role, as I mentioned, in recycling IgG antibodies. So here you'll see on the upper left part of your screen, the IgG antibody comes into an endosome, which gets acidified, and then the antibody then binds very tightly to the right here to the FcRn. This is the IgG antibody, this is the FcRn, and that protects the antibody from going into basically the washer and dryer cycle here, the lysosome, which destroys and degrades unneeded proteins. So it protects it, and then it sends it back out to the circulation. So what efgartigimod does, well, it just it binds to the FcRn, and if you bind the FcRn, then the IgG is left to go to the washer and dryer cycle, and it basically gets destroyed, and that's how that works. And here's a wonderful illustration and explanation of how this technology works and how this drug works. These are the pharmacodynamics of efgartigimod in humans. And basically, this is from the phase 2 study, not the phase 3, which I'll discuss in a second. But you see efgartigimod is in green and the placebo is in black. These are the amounts of IgG. So if you give efgartigimod, the patients on placebo, there's no change in their IgG levels. It stays the same, despite those 4 infusions, 1, 2, 3, 4. But in patients that are treated with efgartigimod, the amount of IgG goes down over 3 weeks and then gradually comes back up by day 65 or so. So the drug really knocks down IgG levels, and this is demonstrated here. So this is the phase 3 study that was published last year. So this is the large, international, multi-center, double-blind, placebo-controlled study to see, if patients would actually, with myasthenia would do better on efgartigimod. And this is, again, the primary outcome, looking at the MG-ADL score, okay? And these are weeks. And you see these are 2, 4, 6, 8 weeks. And red is placebo, so patients that didn't get the drug, and blue is the drug. And you'll see that the MG-ADL score declines. And then we'll go back up by week 8, kind of and then by week 10 or so, it gets pretty close to where it was originally. Whereas the placebo, the patients treated on placebo, they didn't really have nearly as much. And very clearly statistically significant here. There's no overlap between these bands in the plots. So a very, very compelling illustration that disease activity goes down with efgartigimod. This is the QMG score. So another outcome to show whether there's a change. Again, the treated patients have a decline in the QMG score that again peaks at about 4 weeks, for both, and then kind of starts coming back up again at 10 weeks. And it's statistically significant, quite different here from the patients using placebo. And this is the adverse events. Again, efgartigimod versus placebo. Any adverse event, 77% for efgartigimod, placebo 84% higher. Any serious adverse event, 5% for efgartigimod, 8% for placebo. So for a medication that knocks down IgG, which is an important part of the immune system, there actually wasn't infections were not really a significant concern. I mean, maybe upper respiratory tract a little bit more, and urinary tract infection a little bit more, but in general, no serious infections recorded in this clinical trial. So overall, an acceptable, not perfect, of course, but an acceptable side effect profile. And it was this data that led to the approval of this drug, which is also it's an intravenous infusion, but it's taken in cycles. You get 4 weekly infusions, and then you sort of get retreated on an as-needed basis. Presumably, every 8 weeks, would be probably, based on the data, would seem reasonable. But if you can go longer without the treatment, that would be great too. I mean, the fewer treatments you get to have a good outcome, the better it is. So always something to keep in mind. And then the last medication I want to talk about is Rituximab. I want to make a distinction, as I mentioned earlier. This is not FDA approved, but it does have a very important role as a second-line agent for the management of MuSK myasthenia. So this is an anti-CD20. So again, it's a monoclonal antibody. It takes advantage of the properties of antibodies that can be very, very, specific as to what they bind to. And these are designed, biotechnological tools are used to sort of come up with an antibody that binds to the CD20 antigen, which lives on the surface of B cells. So basically, through antibody-dependent cytotoxicity or complement-dependent cytotoxicity, there's different ways of basically knocking down B cells. And the B cells make the antibodies. So if you can knock down the B cells and you can have fewer antibodies, that also includes let's see. So you knock down the antibodies, and let's see. I was just seeing a question, and I got a little. Okay. So so you basically you knock down the antibodies, and antibodies is what mediates MG disease activity. So the hope is that you can control disease that way. Okay. So here's an important point to make. This is a little bit, don't look at the slide too much. Look aside if you prefer. I'm just going to explain it. So basically, the B cells have like a whole sequence of cells that eventually lead to the plasma cell, which produces the antibody. Rituxan is anti-CD20. And so basically only these progenitor cells in the B cell lineage have the CD20 signature. So when you knock down the B cells, you knock down with Rituximab, you only get these guys. You don't get the plasma cell because the plasma cell does not have that CD20 antigen, that signature on it. So it can't be identified by the Rituximab and sort of injured or knocked out, I should say. So that's an important distinction, and you'll see why. There's another example of why that's important in a second. Okay, so for rituximab, I mean, the important thing to know is that it's a game changer for MuSK-MG. MuSK-MG is so rare, truly, an unusual condition that there's no randomized double-blind studies, but retrospective studies show that there's very clinical experience indicate that it's a very important medication for management of MuSK-MG. Now, what about the BEAT-MG trial? The BEAT-MG trial was a trial to see, well, does rituximab work for the most common myasthenia, the acetylcholine receptor antibody positive myasthenia gravis? And the answer is that in that study, this was a negative study. For AChR, acetylcholine receptor antibody positive, rituximab, doesn't seem. This was a negative study. This was steroid sparing effect, and you'll see the curves don't separate. This is a little bit hard to look at, but the bottom line is patients on rituximab did not need less steroid, less corticosteroid. So, and then if you look at another outcome measure, the myasthenia gravis composite score, also it overlaps between the two groups. It's not better. But is that the whole story? And I think this is probably one of the, this is a really, really neat study, and the last study that I'll be presenting today, before we try to leave some time for questions. So, so is that the whole story with rituximab? Rituximab just, doesn't work for the most common type of myasthenia gravis. Well, this group here, in a study that was published, I think just a few weeks ago, like in September, they said, well, what if we try treating patients that are just recently diagnosed with myasthenia gravis, and just do the traditional treatment, prednisone, azathioprine, whatever you're doing, but also give them a little bit of rituximab at the time, at the initial time of diagnosis. And the idea was this idea. And it's really a really neat idea. They said, well, look, there might be a different effect if we give it to patients that have onset of symptoms within 12 months, as opposed to the BEAT-MG patients, the previous study that I showed, where time from diagnosis to treatment was 5.5 years, or 6.7 and 4.4, if you look at the different groups. So basically like 5.5, 6 years. So what if we give it to patients like within 12 months of being diagnosed? And what's the idea there? The idea there is that the plasma cells right here are not affected by rituximab, because you're only getting these guys. So if you've had myasthenia for 5 years, you can develop a stable population of plasma cells that will linger even if you treat with rituximab, because with rituximab, you're only knocking down this one and this one and this one and this one and this one. Or actually, no, this one, this one, and this one. But you're not touching the plasma cell, which produces the antibody. So they said, why don't we just give it early so you never get a chance to produce such a large population of plasma cells that are producing, all these AChR antibodies? Can we just prevent the disease from manifesting, by sort of preventing those plasma cells that produce the antibody to come into existence? Let's see. Okay, and then this is the primary outcome, which is the proportion of patients with minimal disease manifestations, which is defined as a QMG score of less than 4, and a dose of prednisone of less than 10. So if you meet those, so basically look at this graph here. So 16 weeks, 24 weeks, 36 weeks, 48 weeks. And the patients on placebo, the proportion that didn't get the early dose of rituximab, the proportion with this sort of minimal manifestations, 25% versus 70%. 24 weeks, again, much better than the patients on placebo. And then at 48 weeks, again, the patients that got rituximab early on, the proportion that have minimal disease manifestations is like 70% as opposed to 50%. So, this is a smaller study. This will, need to be repeated. But if it is repeated, it will change the management of myasthenia. In fact, I think there's also a reason, if you're having recently diagnosed patients with myasthenia, to strongly consider using this protocol to try to prevent the disease of from developing further. So this is sort of a summary kind of slide, about these novel agents. Eculizumab, it's IV every 2 weeks. Onset of action is 2 weeks. The side effect profile, generally mild, of course, keep in mind, the meningococcal meningitis, although there hasn't been a lot of that in, it's been very limited in myasthenic patients. The cost is high. I have 2 references here. It's very hard to get like real per year, right? 700,000 per year. It's very hard to get accurate prices, but I did try to look this up as best as I could. Prices may change, but I have 2 references for that one. Ravulizumab, that's every 8 weeks. So same mechanism of action, but every 8 weeks. So a lot easier to use. Onset of action, 2 to 4 weeks. Of course, you need vaccines. I wasn't able to verify the cost, so I didn't include it. Farmakidis, 4-week cycles, and then as needed. A mild side effect profile, and this is the price based on 1 reference. Rituximab, there's questions about, whether it works. It's also intravenous. This one has more infusion reactions, so and more adverse events in general, I would say, than some of the other drugs. Considerably more affordable. And then IVIG, also used for maintenance, often every 4 weeks. Onset of action is 1 to 2 weeks, and it's generally well tolerated. And then younger patients seem to have less of a thrombotic risk, and this is also quite expensive, but it would seem to be more affordable than some of these other options. So take-home points. More thymectomy is great. I know we didn't talk about this, but thymectomy is amazing because it allows you to have, if you're acetylcholine receptor antibody positive, it's great because after the procedure, you need both less treatment and you have less disease. So it's kind of like a way to getting towards a cure. Less treatment, less symptoms. So we need more things like that. And then, you wonder, can rituximab do that? You give it early, and then you have, a lesser requirement for medication in the future, or you basically just have, a more responsive disease. We're in an era of drug discovery. There's a great need to find predictors for what treatment will work for what patient. Right now, that's not really, we don't have a lot of information. I mean, which of the patients will respond to which of these increasing number of drugs that are available. For patients and, patient advocate communities, one day we'll need to do comparative, it would be great to do comparative effectiveness trials where some of these new drugs are tested head to head to see what works better and to get more information on cost effectiveness of these drugs, one compared to the other. Clearly myasthenia gravis outcomes have dramatically improved, in the last 50, 70 years. But there's room, there's a lot of room to go, both with effectiveness and also for access, both in North America, but also the world. So thank you for your attention, and maybe Marissa can moderate questions.
Yes, absolutely. Thank you so much, Dr. Farmakidis. Very informative presentation. Let's check the chat. If you do have any questions, you can use at the bottom right hand of your screen, there's like a little question mark button or a chat bubble. Click on either of those and enter in your questions. Looks like here's one question. How can we get more options for LRP4 MG patients?
LRP4 is really, really uncommon. So it's going to be hard to get, it's close to not, basically not possible or exceedingly hard to do large studies. I do think that, IVIG could reasonably work. I do think that Farmakidis could reasonably work. I'm less certain about the terminal complement inhibitors. So I think there are options. And, the better we understand the pathophysiology of LRP4, the better we'll be able to get a sense of what patients will respond to.
Another question came in. On average, how often are your patients being infused with efgartigimod. Do you
Yes.
see most or every 4 weeks, or?
So it's basically 4-week cycles of where in those 4 weeks you get an infusion once a week. So 4 infusions once a week over 4 weeks, and then you kind of wait and see when you need your other 4 treatment infusion. You know, the FDA label, it says as needed afterwards. It doesn't define, you know, it's not like every 4 weeks or every 8 weeks. It's undefined. It's as needed. You know, I have a couple of patients, you know, a gentleman was able to go, you know, 10, 12 weeks. Another gentleman, you know, basically had to do closer to 8 weeks. If you look at the study graphs that we looked at earlier today, you'll see that the antibody levels go back to, you know, what they were previously in about, you know, the antibody levels and also the disease activity at 8 or 10 weeks gets pretty close to where you were before. So every 10 weeks would be reasonable. You might even need to do it sooner, but you don't want to do it too much. You don't want to do it too little.
Great. Just looking here. Does your institution make it a common practice to check IgG levels as baseline prior to initiation of Rituximab to prevent secondary immunodeficiencies?
No. You can, you know, you can check a couple of different things like anti-CD20 levels before you knock them down. You can check IgG levels. You should certainly check like the patient's hepatitis status because you can have reactivation of hepatitis. But these protocols for labs before Rituximab are not standardized. So, and I can tell you in our institution, we do not routinely check baseline IgGs to my knowledge.
All right, just a couple more here. What does the future look like for MuSK-MG drugs?
I think, I mean, I think I would say a couple of things. I mean, I think Rituximab seems to work really well. So, you know, if the patients do not tolerate prednisone or require a large amount of prednisone, they should quickly go to Rituximab. And I think there's no reason to think that efgartigimod would not work. So I think, you know, in some ways, like there are options here. You know, there's multiple options. So efgartigimod could work. Rituximab has been, you know, there's a clinical experience that suggests that it really works. The terminal complement inhibitors would, you know, we don't think the complement is part of MuSK, so they don't have a role in the management of MuSK. So I think sort of the emphases here are efgartigimod, Rituximab, IVIG. You know, those are the, you know, the main things that are available.
Great. Another question on your slide for MG treatment options. How do you decide when to choose a third line agent now that we have a lot more options?
So it's very, you know, I think I considered saying this, but you know, in the take home slide, I was going to say, you know, there's, you know, an era of like drug discovery, you know, there's a lot of things, you know, an era of drug discovery is what I said. And I was almost going to say, well, there's also an era of like lack of clarity, you know, it's, there's no clear standard way of navigating this. We don't know which patients will respond to what treatment. I mean, wouldn't it be nice if you have AChR antibody positive MG to run an assay and say, yeah, you know, your biomarkers indicate that you would respond to this one the best. So, you know, whereas you have another signature of your disease, you know, pathophysiology that suggests that this one would not be good for you. So basically, everyone's different. There's no standard way. You know, a lot of it has to do with two things. Are you having good symptom control, number one? And number two, are you tolerating the current treatments? If you don't have symptom control, you escalate. If you don't tolerate the current treatments because you're gaining weight with prednisone, you're having high blood sugars, high blood pressure, you're having liver toxicity from azathioprine, then you go to these other agents. And then between the agents, you just look at the patients and try to get a sense what may work best. But there's no standard way.
We just have time for one more quick question. Are there irreversible consequences, either pathophysiologic, clinical functioning, for patients with uncontrolled MG beyond what you described with RTX?
Beyond what I described with RTX, with Rituximab?
I'm assuming that's what it means.
Huh. Marissa, can you read the question one more time? Are there...
Do you see it there in the chat? It says, are there irreversible consequences?
No, I'm like looking, I'm sorry, I'm looking at my slides, but there's got to be a better way. Let me,
It just says, are there irreversible consequences for patients with uncontrolled MG beyond what you described with Rituximab?
Okay, so I mean, there are uncontrolled MG, there can be consequences. The main one, and thankfully we don't see this anymore. I certainly, haven't seen it, in the last, 10 years of practice, where I've been, practicing independently, which is burnt out MG. And it's this notion that there's been so much damage at the neuromuscular junction over time that basically you can't really, the disease doesn't respond to treatment because the underlying, space of the neuromuscular junction is so damaged that you've lost so much architecture that you can't really regenerate it. So you can't respond to treatment. And that's called burned out MG. And you might have sort of fixed weakness that doesn't respond to treatment. So those are the consequences of uncontrolled, chronic uncontrolled MG from a physiologic standpoint. Beyond the clinical stuff, which can be just having very profound symptom burden, and of course, life-threatening weakness, with the respiratory weakness, for example.
All right. Well, we covered most questions. I'm sorry that we didn't get to all of them, but Dr. Farmakidis, thank you so much for being here today. We appreciate you sharing your time, your expertise with us, and with the community. So thank you.
Thank you so much. Thank you so much for having me. It was a pleasure to be able to join the event today. Thank you for having me. I appreciate it.
Thank you.